While the etiology and pathophysiology of schizophrenia remain unclear, a large body of evidence suggests that alterations in several neurotransmitters systems, including dopamine and serotonin, may be involved in the pathophysiological processes and are thought to be associated with the development of symptoms. The potential role of the dopamine system in schizophrenia has been researched for many years, including 4 of the dopaminergic pathways. The central dopamine hypothesis for schizophrenia states that there may be dysregulation of 2 dopaminergic pathways, the mesolimbic and mesocortical pathways. It is theorized that an imbalance in these pathways may be involved in mediating the symptoms of schizophrenia. For example, as such, it is postulated that some of these symptoms are a result of hyperdopaminergic activity in the mesolimbic pathway and hypodopaminergic activity in the mesocortical pathway. 2 other pathways to note are the nigrostriatal and the tuberoinfundibular pathways. The potential role of serotonin, also known as 5-HT, in the pathogenesis and treatment of schizophrenia has also been extensively studied. Quantitative differences in several 5-HT receptors have been found in schizophrenia by several investigators, and pharmacological alterations in serotonergic systems have been correlated with symptoms of schizophrenia. The intrinsic activity of any drug is the degree to which the drug activates a receptor. A drug that produces activation of the receptor is considered an agonist. Endogenous chemicals, neurotransmitters, and drugs that produce the maximal response are considered full agonists. In other words, full agonists are expected to have full intrinsic activity. In contrast to an agonist, an antagonist binds to a receptor and prevents binding by other molecules, therefore blocking the stimulation by an agonist or of the endogenous chemical or neurotransmitter. Thus, antagonists do not have intrinsic activity. Another classification of drugs is partial agonists. These drugs can bind to a receptor but evoke a lesser response than a full agonist. The ability to produce a partial effect is generally attributed to the partial intrinsic activity. The atypical antipsychotics available today have affinity for various receptors, and depending on the agent and the receptors involved, these drugs have combinations and degrees of intrinsic activity, including agonism, antagonism, and partial agonism. ABILIFY MAINTENA, aripiprazole, is the first long-acting injectable formulation of a dopamine D2 partial agonist. ABILIFY MAINTENA is indicated for the treatment of schizophrenia. Efficacy was demonstrated in a placebo-controlled randomized withdrawal maintenance trial in patients with schizophrenia, and additional support for efficacy was derived from oral aripiprazole trials. The atypical antipsychotic ABILIFY MAINTENA has a boxed warning: increased mortality in elderly patients with dementia-related psychosis. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk, 1.6 to 1.7 times, of death compared to placebo, 4.5% versus 2.6% respectively. Analyses of 17 placebo-controlled trials, modal duration of 10 weeks, largely in patients taking atypical antipsychotic drugs, revealed a risk of death in drug-treated patients of between 1.6 to 1.7 times the risk of death in placebo-treated patients. Over the course of a typical 10-week controlled trial, the rate of death in drug-treated patients was about 4.5%, compared to a rate of about 2.6% in the placebo group. Although the causes of death were varied, most of the deaths appeared to be cardiovascular, such as heart failure or sudden death, or infectious, such as pneumonia, in nature. ABILIFY MAINTENA is not approved for the treatment of patients with dementia-related psychosis. The mechanism of action of aripiprazole in the treatment of schizophrenia is unknown. However, the efficacy of aripiprazole may be mediated through a combination of partial agonist activity at D2 and 5-HT1A receptors and antagonist activity at 5-HT2A receptors. Actions at receptors other than D2, 5-HT1A, and 5-HT2A may explain some of the other adverse reactions of aripiprazole. For example, the orthostatic hypotension observed with aripiprazole may be explained by its antagonist activity at adrenergic alpha-1 receptors. In schizophrenia, it is thought that there is a hyperdopaminergic environment in the mesolimbic pathway. The mechanism of action of aripiprazole in the treatment of schizophrenia is unknown. Through aripiprazole's proposed mechanism of action, aripiprazole may help decrease dopamine activity in a hyperdopaminergic environment. And it is also believed that there is a hypodopaminergic environment in the mesocortical pathway. It is thought that aripiprazole may help increase dopamine activity in a hypodopaminergic environment. The mechanism of action of aripiprazole in the treatment of schizophrenia is unknown. ABILIFY MAINTENA is the first commercially available long-acting injectable formulation of a dopamine partial agonist. Indication and important safety information for ABILIFY MAINTENA, aripiprazole for extended-release injectable suspension. Indication: ABILIFY MAINTENA is an atypical antipsychotic indicated for the treatment of schizophrenia. Efficacy was demonstrated in a placebo-controlled randomized withdrawal maintenance trial in patients with schizophrenia, and additional support for efficacy was derived from oral aripiprazole trials. Important safety information: increased mortality in elderly patients with dementia-related psychosis. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk, 1.6 to 1.7 times, of death compared to placebo, 4.5% versus 2.6% respectively. Analyses of 17 placebo-controlled trials, modal duration of 10 weeks, largely in patients taking atypical antipsychotic drugs, revealed a risk of death in drug-treated patients of between 1.6 to 1.7 times the risk of death in placebo-treated patients. Over the course of a typical 10-week controlled trial, the rate of death in drug-treated patients was about 4.5%, compared to a rate of about 2.6% in the placebo group. Although the causes of death were varied, most of the deaths appear to be cardiovascular, such as heart failure or sudden death, or infectious, such as pneumonia, in nature. ABILIFY MAINTENA is not approved for the treatment of patients with dementia-related psychosis. Contraindication: known hypersensitivity reaction to aripiprazole. Reactions have ranged from pruritus urticaria to anaphylaxis. Cerebrovascular adverse events, including stroke. Increased incidence of cerebrovascular adverse events, such as stroke, transient ischemic attack, including fatalities, have been reported in clinical trials of elderly patients with dementia-related psychosis treated with oral aripiprazole. Neuroleptic malignant syndrome, NMS. A potentially fatal symptom complex, sometimes referred to as NMS, may occur with administration of antipsychotic drugs, including ABILIFY MAINTENA. Rare cases of NMS occurred during aripiprazole treatment. Signs and symptoms of NMS include hyperpyrexia, muscle rigidity, altered mental status, and evidence of autonomic instability, such as irregular pulse or blood pressure, tachycardia, diaphoresis, and cardiac dysrhythmia. Additional signs may include elevated creatine phosphokinase, myoglobinuria, rhabdomyolysis, and acute renal failure. The management of NMS should include 1. Immediate discontinuation of antipsychotic drugs and other drugs not essential to concurrent therapy. 2. Intensive symptomatic treatment and medical monitoring. And 3. Treatment of any concomitant serious medical problems for which specific treatments are available. Tardive dyskinesia, TD. The risk of developing TD, a syndrome of abnormal involuntary movements, and the potential for it to become irreversible are believed to increase as the duration of treatment and the total cumulative dose of antipsychotic increase. The syndrome can develop, although much less commonly, after relatively brief treatment periods at low doses. Prescribing should be consistent with the need to minimize TD. There is no known treatment for established TD, although the syndrome may remit, partially or completely, if antipsychotic treatment is withdrawn. Metabolic changes. Atypical antipsychotic drugs have been associated with metabolic changes that include hyperglycemia, diabetes mellitus. Hyperglycemia, in some cases extreme and associated with ketoacidosis, coma, or death, has been reported in patients treated with atypical antipsychotics, including aripiprazole. Patients with diabetes should be regularly monitored for worsening of glucose control. Those with risk factors for diabetes should undergo baseline and periodic fasting blood glucose testing. Any patient treated with atypical antipsychotics should be monitored for symptoms of hyperglycemia, including polydipsia, polyuria, polyphagia, and weakness. Patients who develop symptoms of hyperglycemia should also undergo fasting blood glucose testing. In some cases, hyperglycemia has resolved when the atypical antipsychotic was discontinued. However, some patients required continuation of antidiabetic treatment despite discontinuation of the suspect drug. Dyslipidemia. Undesirable alterations in lipids have been observed in patients treated with atypical antipsychotics. There were no significant differences between aripiprazole and placebo-treated patients in the proportion with changes from normal to clinically significant levels for fasting, non-fasting total cholesterol, fasting triglycerides, fasting low-density lipoproteins, LDLs, and fasting non-fasting high-density lipoproteins, HDLs. Weight gain. Weight gain has been observed. Clinical monitoring of weight is recommended. Orthostatic hypotension. Aripiprazole may cause orthostatic hypotension. ABILIFY MAINTENA should be used with caution in patients with known cardiovascular disease, cerebrovascular disease, or conditions which would predispose them to hypotension. Leukopenia, neutropenia, and agranulocytosis. Leukopenia, neutropenia, and agranulocytosis have been reported. Patients with a history of clinically significant low white blood cell (WBC) count or drug-induced leukopenia, neutropenia should have their complete blood count monitored frequently during the first few months of therapy while receiving ABILIFY MAINTENA. In such patients, consider discontinuation of ABILIFY MAINTENA at the first sign of a clinically significant decline in WBC count in the absence of other causative factors. Seizures, convulsions. ABILIFY MAINTENA should be used with caution in patients with a history of seizures or with conditions that lower the seizure threshold. Potential for cognitive and motor impairment. ABILIFY MAINTENA may impair judgment, thinking, or motor skills. Instruct patients to avoid operating hazardous machinery, including automobiles, until they are certain ABILIFY MAINTENA does not affect them adversely. Body temperature regulation. Disruption of the body's ability to reduce core body temperature has been attributed to antipsychotic agents. Advise patients regarding appropriate care in avoiding overheating and dehydration. Appropriate care is advised for patients who may exercise strenuously, may be exposed to extreme heat, receive concomitant medication with anticholinergic activity, or are subject to dehydration. Dysphagia. Esophageal dysmotility and aspiration have been associated with ABILIFY MAINTENA. Use caution in patients at risk for aspiration pneumonia. Alcohol. Advise patients to avoid alcohol while taking ABILIFY MAINTENA. Concomitant medication. Dosage adjustments are recommended in patients who are CYP2D6 poor metabolizers and in patients taking concomitant CYP3A4 inhibitors or CYP2D6 inhibitors for greater than 14 days. If the CYP3A4 inhibitor or CYP2D6 inhibitor is withdrawn, the ABILIFY MAINTENA dosage may need to be increased. Avoid the concomitant use of CYP3A4 inducers with ABILIFY MAINTENA for greater than 14 days because the blood levels of aripiprazole are decreased and may be below the effective levels. Dosage adjustments are not recommended for patients with concomitant use of CYP3A4 inhibitors, CYP2D6 inhibitors, or CYP3A4 inducers for less than 14 days. Most commonly observed adverse reaction. The safety profile of ABILIFY MAINTENA is expected to be similar to that of oral aripiprazole. In patients who tolerated and responded to oral aripiprazole and single-blind ABILIFY MAINTENA and were then randomized to receive ABILIFY MAINTENA or placebo injections, the incidence of adverse reactions was similar between the two treatment groups. The adverse reaction greater than or equal to 5% incidence and at least twice the rate of placebo for oral aripiprazole versus placebo respectively was akathisia, 8% versus 4% in adult patients with schizophrenia. Injection site reactions. In the open-label stabilization phase of a study with ABILIFY MAINTENA in patients with schizophrenia, the percent of patients reporting any injection site-related adverse reaction was 6.3% for ABILIFY MAINTENA-treated patients. Dystonia is a class effect of antipsychotic drugs. Symptoms of dystonia may occur in susceptible individuals during the first days of treatment and at low doses. Pregnancy, nursing. Based on animal data, may cause fetal harm. ABILIFY MAINTENA should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. Aripiprazole is excreted in human breast milk. A decision should be made whether to discontinue nursing or to discontinue the drug, taking into account the importance of the drug to the mother. Please see accompanying full prescribing information, including boxed warning, for ABILIFY MAINTENA.